Good morning, and this is my pleasure to be here to talk about some very interesting case. This is a transmission from Nanjing First Hospital, China, and in case lab 4, this patient's operator is Dr. Ge Zheng, and would you please, Dr. Ge Zheng, to introduce your heart team and the information of the patient, please?
Okay, thank you, Dr. Ye. This is Nanjing First Hospital, cast number 4, and I'm very pleased to here introduce this case. First of all, I want to introduce our team. This is on my right is Dr. Gao and Dr. Xie, and imaging technician is Dr. Pan and nurses. So first of all, I want to ask the Dr. Gao to introduce this case clinical information. Thank you, Dr. Gao. Please.
Okay. Hello, everyone. It's my honor to introduce this case. This patient is 34-year-old gentleman who was admitted into our hospital, presenting with exertional chest discomfort for 2 years, aggravated for 1 month. His risk factors included hyperlipidemia and current smoking. Lab tests at our hospital showed his eGFR and BNP were normal. ECG were normal. Echo found his left ventricular ejection fraction 66%. He was diagnosed with unstable angina. Next. Almost 1 month ago, this patient received coronary angiography at our hospital. The baseline angio showed the severe, almost 90% stenosis in the distal right coronary artery. And this patient was very young, 34-year-old gentleman. He refused cabbage, refused metal stand implantation. So after heart team discussion, we performed DCB dilation in the distal right coronary artery. The residual stenosis is less than 30%. The TIMI flow is 3. No severe dissection. It's good. Next. Today, the target lesion is the left coronary artery. The only mild stenosis in the distal left circumflex. Next. From epicranial and iocranial, we could find a severe stenosis in the proximal LAD. Fortunately, no diagonal involved. No severe calcification. Next. Syntax score for this patient was only 7. We also calculated syntax 2 score. 4-year mortality for PCI was 1.4%. 4-year mortality for cabbage was 0.6%. Next. Because this patient refused cabbage and metal stent, so today we plan to perform OCT-guided BIS implantation. Thank you. That's all.
Okay, thank you, Dr. Go. Introduce this case clinical information. Summarize this case is a very young patient, just 34 years old male. Because unstable angina admitted to our hospital, angiogram shows distal RCA is severe stenosis, and because RCA is a small vessel, just 2.25, use because the patient declined to the mechanical stent implantation, so we use the DCB for the right artery, right artery. And today the target lesion is LD. This LD is from the angiogram, seems like the simple lesion is located the proximal LD. So because the patient continue to refuse the mechanical stent implantation, so because this LD proximal LD lesion, so we want to use the BRS for this patient.
Yes, quite an interesting case and very young gentleman. He refused cabbage and metal stent implantation. So how many selection, how many choices of you to perform for this kind of situation for the very young patient? Is there any difference for the BVS and DCB?
Oh, it's a great question because this patient is very young. For the younger patient or some patient, high bleeding risk patients, probably we don't want to use the mechanical stent implantation. We use the drug-eluting coated the balloon for these cases. And for this case, because the younger patient is lesion is simple, is and type the A or B1 lesion. So also the right artery is a very small vessel. It's not suitable for the BRS. So we use the drug-coated balloon for this artery, right artery. For the LG, because the larger vessel is also is located the proximal LG. We concern the prepare the lesion and occur the dissection or some of the hematoma. So we use the BRS for this patient is a good choice.
Yes, you plan to use BVS or BRS for treating proximal LAD lesion. So I saw you perform the PCI procedure from the left radial approach. So what's the size of the guiding caster, and which kind of situation if you met some resistance during pushing the guiding caster?
Yeah, even the patient is very young, is a strong man, but this last PCI, the right radial artery is occlusion.
Okay.
So we chose the left radial artery for this procedure.
Yes.
And we input the six French the sheath into the left radial artery, and want to use the EBU 3.75.
Yes.
And to advance, but is we get some of the resistance. So
So-
I want to some of the method to deal with this problem.
So
And yeah,
yes, how many? I mean, so how many methods you want to resolve? Deal with this problem.
yeah, I also give some the nitrous for
Nitrous?
this. Yeah,
First,
to
nitrous.
yeah uh, to relieve the spasm of the radial artery spasm.
Yeah,
Yeah, but it's not a success.
it
So
didn't work.
yeah, so I want to another place use the five French the
Okay,
the French yeah it's fiber tank tiger.
yes, it's very useful methods to resolve this problem. Use a 5-in-6. Please zoom the table. We will see how to perform the problem. If you push the guiding caster failed,
Insert the five French catheter into the six French
could
catheter.
you show us the tip of the guiding caster? It's a 5-in-6.
5-in-6.
Yes, the
Okay.
tip of the guiding caster. Tip.
Tips here.
We can see the five peak tile was ahead of the guiding caster. Okay.
Yeah,
Yeah.
So you push the two casters
Together.
simultaneously.
Yeah.
Okay. We'll see.
And
Go.
to advance
Still,
this
yes.
to
You still feel some resistance?
no.
No.
It's,
Okay, it's
smoothly.
quite easy.
Yeah. Okay. Hold the wire. Yeah. Okay. It's,
Please show.
Okay.
Yes.
no.
So we can see if we met some resistance during pushing the guiding caster with even though we use a 6-French guiding caster, we can use nitro to resolve the spasm of the radial artery, and we also can use 5-in-6 tactic. We also have some another tactics just like balloon assist tactic, and we can use a 5-in-6 microcaster. Okay, we also can use double wire tactic, and if still failed, we will use so many kinds of methods to resolve this problem. We can see Dr. Ge use 5-in-6 tactic to resolve the guiding caster the resistance during the pushing the caster from the radial artery.
Okay,
So
this is 3.75.
this is 375
Yeah.
EBU.
Yes.
Okay.
Here.
Give a little.
Yeah. Just little. Okay. Small here.
Okay.
No.
Okay.
Just because first time we use a rod radio approach.
Okay.
So we can see from the previous angle, we use JL5 angle caster, show little small. So Dr. Ge selected the 375 EBU guiding caster for LED PCI procedure. So which kind of the wire you used
This
for the
is
workhorse wire?
it is a workhorse wire. It's a BMW.
BMW wire.
Yeah.
So if you want to perform a PCI
That's
for the
angel.
proximal LED, you will use which kind of intravascular imaging is your first choice, IVUS or OCT?
So now I could use the OCT to guide
OCT.
the PCI. Okay, we get the best angiogram. Okay, baseline angiogram. Okay. Remove this one. Just a minute. Okay. Angio. Right.
This is AP quarter.
Yeah.
Yeah.
It's epigotal. We
Okay.
can see second phase is a very large vessel, so the artery is small. Here is epicranial. Okay.
Wait a moment.
Yeah, angio. Yeah, we can see
Ah.
lesion. Look at the proximal LD. Okay. Yeah.
Yes, this is a RL cranial. We
It's
can
RL.
see the severe stenosis at the proximal LED. We also kind of from the angle, the haziness phenomena. We don't know the plaque characteristics from the angle. Yes.
Yes. Okay. 要导数。
Okay, you got it. Please move the table. Yeah. So this is a BMW wire.
Yeah.
Okay.
Okay. It's enough.
So you want to check the OCT at the baseline?
Yeah.
Okay.
Okay.
Okay. Okay.
Let's use the knife.
So according to your experience, routine to check the ACT before you want to put the BRS?
Yeah. For the BRS or not, the complex PCI and
Yeah.
routine test the ACT.
Mm-hmm.
Yeah.
So how do you think about the lesion preparation between the BRS implantation and the DCB used for deliver lesion?
Yeah, yes, a great question. For this lesion, whatever you use the DCB or the BRS, the preparation for the lesion, that's the important steps before the procedure. So for the BRS, I think, sorry,
Wow.
wait a minute, until once. Okay, here, it's not here. Here, okay, you can see. Okay. It's enough.
Okay.
Okay.
Yeah.
Okay.
Okay. To check the guiding
Yes.
is the cool
Axel.
axial. Yeah.
It's very, very important to make the guiding cast Excel for Excel. If we want to obtain a high quality of OCT imaging.
Okay.
Professor, are you ready?
No, test.
Okay.
Test.
Test.
To show the guiding caster's position.
Yeah.
Okay.
Okay.
Okay, job. But the OCT caster push a little distant.
Okay,
Yeah,
I'm ready.
No.
No.
Push the OCT caster a little distant just
Yeah.
because the sensor was pulled back. Falling back. Yes. Push. Okay.
Yeah.
Okay. So from the OCT imaging, we can see this reference diameter proxima and the lesion characteristics, and we will perform a very good lesion preparation
Okay.
based on the
Yeah, I'm
OCT
ready.
imaging. Yes. Okay.
Okay.
How about the quality of the OCT? It's very good.
Yeah,
Yeah.
flash is very good.
Imaging is good.
Okay. What was the question?
There is some questions from the audience. What is the purpose of a PCI procedure, and in what situation is it typically recommended? So, is the patient still some ischemic symptom or the other ischemic evidence for the ARD lesion? So, if we can see from the angel. From the angel, severe stenosis at proximal LAD. LAD was more important than the RCA, even though for this time of the patient admission, maybe the carpal lesion was RCA, just because RCA was very stenosis, and the TIMI flow was lower than low than TIMI3. So we treated RCA first, but the RCA LAD was a long carpal lesion, but still severe stenosis. From the proximal prospector study, we also can see the future events related to the carpal, long carpal lesion was equally. So for this kind of situation, for the proximal LAD, severe stenosis, we should treat it first. So, Dr. Pan, would you explain the result of the OCT at the baseline?
Okay, let me show the OCT imaging. We can see the distal landing rule here, and near the diagonal, about 2 millimeter, and here the vessel diameter is about 3.5.
Okay.
3.5, and the lumen diameter is about 2.9 millimeter. And the proximal landing rule here is lots of lumen vessel, and here the lumen diameter is about 3.3 millimeter. And here this point is the minimal lumen area, and the area is just 1.2 millimeters square.
Yeah.
And here the plaque is a lipid plaque. And the netness from the distal landing rule to proximal landing rule about 23 millimeter. Okay, this is baseline OCT.
23. How about the distal diameter and the proximal reference diameter?
This
3.5.
is 3.5. Vessel is 3.5.
Okay, median to median is 3.5 at the distal part of LAD lesion, and the proximal is lumen diameter. Is 3.5. 3.3. 3.3. Okay. So, Dr. Ge, what's your strategy for the lesion preparation based on the OCT finding?
Yeah, based on the OCT measurement, and we can lesion is a nipped lesion, nipped plaque. So I want to prepare the patient, the lesion, use cutting balloon.
Yes, cutting.
Yeah.
Even though the lesion was lipid, no, a little larger. 325 is that 30? 325. 30. Okay.
3.0切割。
Yes, from the OCT, we also can find the fibrous cap was very thick. So I think cutting is suitable for this kind of situation. I mean, so for the lesion. So lesion preparation is very important if we want to perform a DCB or BRS implantation, compared with a metal stent implantation. Just because we don't want to perform very high personalization in the BRS or the after DCB.
哦，明白，我知道，I know。
So
The cutting balloon.
there is another question. What are the potential risks and the complications associated with the PCI?
On
PCI for this patient, the potential risks
just
and the complications is
okay.
we will see the lesion preparation. If there is low
2, 4,
Because
6.
oh yeah, good.
maintain,
Mm,
okay,
Yeah, good.
we can see with what's the pressure?
8.
8.
Mm.
8.
Mm.
So not very high of pressure. We can see the cutting balloon for expansion.
Just a little bit. Okay. Here.
Okay.
2, 4,
6, 8.
6, 8.
Okay.
Okay.
Very good.
The balloon expansion very well. Okay. Good. And go back a little bit.
So what's the length of the cutting balloon? 6 or
This is-
10?
Oh,
No, stop.
God.
For back. We will see the flow.
Yeah. Okay.
Nah, check the flow.
Okay,
Okay,
good.
okay. Just because the profile of the cutting balloon was larger compared with the conventional balloon and the NC balloon, so that's why we cannot find any anterior
Oh.
flow after cutting balloon in inflation. So after that, we give the nitro
Yes.
and we check the OCT again.
Good.
If there is low large dissection and the low dissection extend, we can put
不走，直接OCT。
OCT. After lesion preparation with 3O NC balloon, cutting balloon,
cutting balloon.
we find with very high fibrotic lesion, cutting is very useful for lesion preparation. There is low slippery phenomena during the balloon inflation. If we use a conventional balloon or NC balloon, we will find the balloon slip forward or backward, and it's very easier to find this phenomena. But cutting is very stable. So this is the second OCT run after lesion preparation with a 3O cutting balloon.
Ready?
Wait a moment. Okay, I'm ready.
Rush. Good.
Okay.
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 Yeah. Here we can see the media dissection. But
Media dissection. Okay.
dissection angle is about 60 degrees.
Okay. How about the length?
Length maybe 5 millimeters.
Okay. So sometimes we find the dissection occurred after lesion preparation. If the dissection was deep at the medial membranes and the length of the dissection over 2 millimeter and the angulation of the dissection over 60 degree, we cannot use a DCB. DCB is not safety for this kind of lesion after lesion preparation. I think the BRS is yes. From the angel, we also can find the dissection occurred. Yes. So, Dr. Pan, would you measure the length? Means where is the landing zone and proximal landing zone? Recheck again.
Okay.
Dr. Go, would you
23.
would you to put the BRS directly, or you want to perform another lesion preparation?
I think the preparation is good.
Okay, enough.
I want to put the BRS.
Okay.
Yeah.
Okay.
Okay. Because BRS.
So, and based on the OCT, what's the size of the BRS you will use?
Yeah, that's a great question. Yes, and based on the OCT, the distal reference vessel diameter is 3.5.
Yeah.
Yeah. So I want to use the 3.5 BRS for this case. And the next, next is 21 or 20. Well, next
That's 23.
23.
Yeah.
Okay.
24.
So you select
24.
24.
Yeah,
Okay.
24.
3524. So Dr. Ge, would you tell us what we should pay attention to? Is there a difference of the mental stent implantation and the BRS implantation before we put the stent in the body?
Yeah, that's a great question. This is a BRS is a difference from the mechanical stent. There is a stent needed to store in the bridge below the 2 degree.
Yeah.
And then we take the stent and before the implant the body, 5 minutes.
Okay.
And, so
could you zoom the BRS before put in the coronary artery? Please zoom the BRS.
This BRS is Chinese domestic BRS. It's
Okay.
a new vessel. New vessel.
New vessel.
Yeah.
Okay.
Here.
You put the room temperature situation for 5 minutes?
Yeah.
Okay.
Already? 5 minutes?
No.
No. Okay, this is, yes.
We're waiting 5 minutes?
Okay. We can see from the
discussion
yes.
or the questions.
Okay.
So there is a third question. What? Okay. How effective is PCI in relieving symptoms and improving heart health compared to other treatment options? Relieve symptoms is quite interesting questions. This is a general question, not for this patient. Is there any difference between the PCI and optimal medical therapy for severe stenosis of the patient for this kind of situation? So, Dr. Gao, could you know the prospective study designed by Dr. Greg Sloan?
Yeah.
Okay. So, how do you think about this question?
It's a good question. I think now it still remains controversial about perform PCI for stable coronary disease patient. Because some studies about such as ischemia study, cardiac study did not show PCI was associated with reduced mortality risk compared with GDMT treatment. But for unstable angina patient or ACS patient, we think PCI could reduce the mortality risk. And concerning for this question, it's just relieve symptoms. I think if the patient has severe stenosis, not only stable or unstable patient, I think PCI could reduce could relieve the symptoms.
Yeah, I think so. Just because the question is focused on the symptom, not the death, the hard endpoints. So I think PCI is better. If the composition of endpoints just like symptom and ischemic and hard evidence just like cardiac death, maybe there is no difference. Medical therapy is enough for stable angina, not for unstable angina, especially for the STEMI. So maybe PCI is not suitable for the composite endpoints. But for this patient, especially the lesion located approximately AD, this is very, very important location for the patient. From another indication from the prospective of SOLVE study, we also can see maybe BVS-BR is suitable for very unstable plaque. Maybe in the future, this kind of patients easily maybe transfer to the MACE. So this is maybe not the recommendation and consensus. So we also can see Okay, the final question is Dr. Ge. How much is the struct thickness of the BRS stent?
Yeah, this BRS stent is the thickness is 115 micromilligram.
Okay. So is any new generation of BRS in China?
It's the first generation. I
Okay.
think.
So the another question is how important is it to have a good landing zoom for the BRS? A very, very good question. The final question.
What?
Landing zoom.
Oh.
Landing zoom.
Yeah, landing zoom is important for this PCI procedure. And usually we use the intravascular image to guidance. Usually we use probably is a normal vessel or the some fibrotic plaque. Also, the plaque burden is less than 50%. I think that's a good location to do the landing zoom.
Yes, I think if we use intravascular imaging based on the OCT or IVUS finding, OCT has a criteria of MLD, MX from the light lab study. So just like Dr. Gus saying, if we met this landing zone, we use a normal site or the lesion plaque burden less than 50% without any lipid and inflammation. So we can use this location as this landing zone, approximately just like here. So any information of the BRS implantation, if we use a mental stent to cover lung lesions, this mismatch between the diameter of the proximal part and distal part. So how about the BRS implantation we should pay attention to?
The distal mechanical stent is different from the BRS, and the landing zone, distal landing zone is we should choose the site to put the stent in the distal landing zone, and then we to think about the proximal landing zone. The proximal landing zone usually the diameter between the proximal landing zone or the distal landing zone is less than less than 1 millimeter is a great choice. If the diameter between these two part of greater than 1 millimeter, I recommendation to use the two stent to overlap this long lesion.
I mean, the mismatch between the proximal and distal diameter over 1 millimeter, we should use two BRS implantation with maybe a little overlap or without any overlap or head-to-head technique. So is there 5 minutes?
Yes.
Okay, after we waiting for 5 minutes at the room temperature situation, Dr. Ge inserted a BRS.
Yeah.
So we can see the profile of the BRS was larger than the metal stand. Okay. So do you feel any resistance during pushing?
No.
So this is BRS. We cannot see any mentor.
Okay. Yes.
Okay.
Go back a little bit.
Yes.
Okay. Right here. Probably is good.
Even though we cannot see the scaffold during the Sini? Okay.
Yeah, I think it is a good position.
So could you tell me how to make sure the position is good? We cannot see any mentor here. Is any, I mean, the marker?
Yeah, there's a stand in between the two bar mark distal and the proximal mark.
Yeah.
We can see two marks here.
Mm-hmm.
Yeah. Okay. Yes, and okay.
Yes, we can see
deployment.
the
Okay.
two markers located at the distal and the
Okay.
proximal part of the stand, but the scaffold we cannot see. So your inflation very slowly.
8.
8.
Good. 10. Good.
Okay, 10 atmosphere.
Yeah.
Good. This is 3524 BRS.
Yes. Okay. Put back.
Okay.
So balloon profile. Nice.
Even though we cannot see any mental lived in the coronary artery, we also can see proximal and distal part of the BRS. There is two markers, and the meta markers. If we see the angio carefully. Okay, EKG was okay, and the pressure is okay. After give some nitro, we'll check the angio again.
Yes.
Okay.
Sydney.
Okay, cool.
Oh,
Ah, very good.
Very good.
Very good. Very good. But we also can see some mismatch between the proximal and the distal part of the stand. So you will perform post-dilation first, or you want to check the OCT, and then to decide how to perform a post-dilation.
Yeah, I want to post dilation first name and then
Okay.
check everything. And
Okay.
3.5.
3.5.
Yeah.
8 or
So it's very important for us to maintain the workhouse wire stable. We cannot pull it back and want to find the true, stand lumen. Sometimes we cannot see the scaffold from the angel. We also can see from the OCT. So if we want to perform post-dilation, what's the size of the post-dilation balloon?
Because this PRS can do post dilation, the upper size is just 5 minutes, 0.5 millimeters. So for the distal part of this stand, I want to use the 3.5 non-compliant balloon to post dilate. For the proximal part, probably I may use the 3.75
Okay.
non-compliant balloon to do the post dilation. Okay.
So distal is 1:1
Yeah.
for distal reference.
然后准备个3.75 的
And
球囊。
1:1 for proximal part, you want to select 375.
Yeah. Because we cannot see the
Yes.
mechanical stand, we just use the.
We also can see the marker.
Yes, see some the branch to mark is stand where it is.
Okay.
Okay. Okay.
Yeah.
Yeah.
So the stand marker is very, very useful for post-dilation balloon location.
10,
10.
12.
12.
So this is 3.5.
3.5. Yes.
There is a question. Would you be doing the OCT after BRS?
Yeah.
Absolutely.
Yeah. Oh, but I think the IVS is okay.
IVS is okay.
Yeah.
12.
14.
14.
Right. Okay. 3.75.
375. Is it a BRS you are planning to use?
Sorry.
The final question. Is it a BRS you are
Yes,
planning?
we have used BIS.
Yes.
For this kind of situation, very, very young patient, he refused to get the cabbage and the mental stent implantation recommendation. After we talked with him and his family for several times, he still refused. But for this severe stenosis of the proximal AD, we should treat it just because the lesion was so severe and the plaque burden was so high. And after a lesion preparation with a cutting balloon, we can see the severe dissection occurred. So that's the two reasons why we want to use a PRS implantation for this patient. So this is a 375.
Yes.
Okay, 375. You can see the marker. Yes, marker here.
Okay.
Marker is enough. Yeah, okay. You can see marker. Yes. What's the pressure of the NC balloon?
10,
10.
10.
Okay.
12.
12.
12.
So from the angel, we can see the balloon inflation was very, very, very good. Is this a Chinese BVS?
Yes, Chinese is local company.
So this is a local Chinese bioabsorbable scaffold. The name of the BVS is Nuvas.
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 Yeah,
Okay.
Nuvas.
After personalization with 35 and 375 NC balloon, Dr. Ge will check the OCT to confirm the final result of the BRS implantation.
Yeah.
Okay,
Good.
you see quite easier.
Yeah, it's easy.
Wait a moment.
Yes.
Okay.
Yeah, I'm ready.
OCT.
Okay.
So we can see from the angel after BRS implantation, angel result is quite.
Distal stand age is normal, no dissection.
Okay.
Very good.
The adhesion is
No,
good.
no malposition. Yeah.
No malposition.
No dissection malposition.
Yeah, very good.
The proximal stand is normal, no dissection.
Okay.
Excellent result.
Yeah, great.
Very nice.
Yes. We will measure the stand expansion ratio based on the MLD-MX.
Wait a moment.
Mesh.
Yes.
Mesh. The stand expansion.
Yes, even though we don't have any guidelines and consensus after BRS implantation, the metaposition is first key point we should pay attention after BRS implantation. The second is expansion ratio.
The minimal stand area is about 6.7 millimeters square.
Yeah.
And the distal lumen is about 7.6 millimeters. So the expansion index is about more than 0.8.
Oh, 80%. Okay.
Yeah. It's an acceptable result.
So this part of BRS expansion was acceptable. Okay, how about the middle part and the proximal part? Yes, here. After 375 NC volume post dilation.
Yeah. Lumen diameter is about 3.7.
Okay.
Mean diameter is more than 3.7.
Area.
Area
Instant. 11.
11.
How about proximal reference area? I mean, the proximal part of the stand expansion ratio.
Proximal area.
I think over 90.
Over
Very,
100.
very good. Okay, proximal is better than the distal part of the area.
Yeah.
So from the OCT detection, we can find that there is no metal position and expansion ratio was very, very good. Even we use modern MLD-MX criteria. So we also can see very, very interesting. There is low side branch loss after stand implantation. So could you show me the last questions?
Yeah.
Is there any many questions from the audience? Yes, from the angel we can find the final result. There is low, I mean, it's less than 10% residual stenosis after stand implantation from the angel, and from the OCT, we also can see the OCT result after. I mean, the final OCT result is acceptable. Okay, TIMI flow was very good. No dissection at the proximal distal part of the stand. No metal position, no on-expansion, no side branch loss. Very, very good. And then out of the view, we can, yes.
Correct.
Yes, yes. I have a question to ask Dr. Ge. After BRS implantation, what should we do? That means give the patient dual antiplatelet therapy how long and which kind of medication? Ticagrelor or clopidogrel?
Oh, that's a great question for this BRS implantation. After BRS implantation, the dual antiplantar therapy is great. Is a key issue for this
啊，
case.
他那个有个问题，
Yeah,
我觉得
usually we use two dual antiplatelets at least 12 months. For the ACS patient, we use aspirin or ticagrelor. For the stable angiola patient, we can use the aspirin or the ticagrelor or aspirin or clopidogrel. So at least 12 months. That's the dual antiplantar duration. For some of the patient, if the patient is no risk of the bleeding, probably we can prolong the dual antiplantar therapy for this case. The case to reduce the reduce the stent thrombosis. Usually for some patients, we can prolong to the 18 months or 24 months. That is suitable for this no bleeding of risk of patient.
So according to your experience, is any data in China for the standard scaffold resolve after how long? I mean, 2 years, 3 years, or 5 years?
From the Chinese is the best the BIS is a new vessel is from the Liverpool company. It's RCT and randomized RCT trial to show the 5 years. Some patients give the dual antiplantar therapy, and 3 years is for this no bleeding of patients is safe. Yeah.
For I mean, for your experience or for the recommendation from the Chinese experts, I mean Chinese consenters for the BRS implantation, focal lesion we also can use. If we met some calcified lesion and diffuse lung lesion, is it suitable for BRS implantation?
Yeah, for some patients, long lesions is suitable to use the BRS, but the problem we need to check the distal reference diameter or the proximal reference diameter to show the stent size for this patient. This is the important issue for this patient, long lesion.
So just because the thickness of the BRS was thicker than the conventional mental stent, just because thickness was over 150 millimeter. So if we put a stent, we find the side range was compressed. Which kind of situation you will perform and rewire in the side range and perform kissing? So many key points if we want to perform kissing compared with a conventional mental stent.
Yeah, that's a great question. For the bifurcation lesions, some just study or from our peer experience for some of the bifurcation lesions, we can use the BIS to treat this lesion, but we need to use the wire to protect this sun branch if the OCTM is very stenosis. After that, we probably we use the kissing balloon information. But important issue, we use the balloon for this in-bed vessel, and probably we use the 1-to-1 ratio non-compliant balloon for the main vessel and the semi-compliant balloon for the sun branch to kissing balloon information. Okay.
So the final question is BRS suitable for left main lesion?
Yeah, it's not the contraindication for some patient because the left main is a large vessel.
Yes.
For some is no calcification or no tortuous left main. We can use the BIS for left main disease.
It depends on the diameter of the left main. Just because left main diameter was also very, very often over 4 or 4.5.
Yes.
So the conventional diameter of the BRS in China was about 3.5 and 4.0. But for a very, very large left main disease is not suitable just because the diameter was mismatched. Okay. So, Dr. Ge, would you summary for this case, and we will end the procedure.
Okay, this case because it's a very young patient and the patient refused the metal stent to implant it. So we use the BIS for this case, and BIS is an important strategy for the PSP. The pre-dilation is very great for this case, and then to size stent size choice that's very great for this patient long-term outcomes. So about the stent size, we also use the intravascular imaging to guidance to choose the stent size. And last, we use the post-dilation to do the to make the stent optimization, and then probably to do the long-term outcomes. We are very good.
Thanks, Dr. Ge. Dr. Ge gave us a conception of lasting left in coronary artery, especially for very young patients in China. And we also have two methods. One is a DCB for delivery lesion, and another is a BRS for delivery lesion, especially for the very large diameter vessels. But for small vessels, we also can use DCB to treat, but we still need more evidence to support our conception lasting left in coronary artery, especially for very young patients. Thanks, Dr. Ge, and
Yes.
thanks, Dr. Ge. And we will end our first case in China, Nanjing First Hospital. Thanks very much. And we talk about. Thanks.
Thank you.